Okay, hello everybody. Welcome back once again to the interview series here on the channel. I am absolutely delighted, privileged, and overwhelmed to be joined by Dr. Oren Gottfried, who is a neurosurgeon and a professor at Duke University in North Carolina, who has very, very graciously agreed to speak to us today. Oren, thank you so much for being here.
Oh, thank you for having me.
It's very, very rare that we get someone, I think, of this sort of stature and expertise, and we had loads of questions come through. Would it be okay to start, Dr. Gottfried, just if you could kind of take us through your early career path, just how you came to be where you are, and then later on we'll jump into some questions.
Of course. Well, I gathered an interest in medicine and even neurosurgery during my undergraduate studies. I was always fascinated by the neurological illnesses and the treatment of these complex illnesses that we don't even fully understand, in some cases, etiology or pathogenesis. But I found it fascinating that there would be an approach to treatment. So my interest became further and further refined during undergraduate studies. And then also in medical school, I knew that neurosurgery was right for me. I completed a 7-year neurosurgery training. I was fascinated by the fact that orthopedics and neurosurgery do quite similar work on the spine, but I wanted the perspective of the orthopedic side. So I did a year fellowship with orthopedic surgeons to understand deformity beyond just from a neurosurgery perspective. I also have an interest in spinal tumors and did a fellowship in spinal oncology, and then found myself a position at Duke University and have been at that current faculty position for approximately 11 years now.
Amazing. So really I guess a storied career by the sounds of things, done lots of different things in your time. I suppose there's a lot to get into with that. I mean, if you don't mind us asking, in America, for those listening in the UK, medicine is exclusively a postgraduate vocation, which is not the same in the UK. What did you major in? Is that the term beforehand?
Correct. You're very well versed on all of this. Don't quiz me on the opposite, because I'm here to learn from you. But yes, in undergrad, my focus of study was zoology, and there are institutions in the United States that have pre-medical education, but most people take their whatever route they would like. But the interesting thing is I learned not only about human anatomy and physiology and all subjects, but how it relates to invertebrate and vertebra and animals. So it's just like that random knowledge is kind of fun, where I'm in no means a veterinary medicine specialist. I don't know anything. But it's just nice to, when you go to medical school and learn about all these complex things about the human body and care, I have a perspective of how would it be to take care of this odd animal. So it's good cocktail party conversation, but it actually prepared me well. All of my studies were basically the prerequisite to the medical school studies, classes I needed.
Yeah. And then thinking about neurosurgery then, because again, this is very much from the perspective of an outsider, but neurosurgery, probably across the world, has has a reputation, I should say, for being quite difficult to get into, very competitive. Lots of people want to do it. At what point in medical school did you decide that that's what you were going to do?
Well, I naively came into medical school thinking I wanted to be a neurosurgeon. And I think those ideas, before we have the actual fundamental educational background to back it up, are just that, naive. But if you're really driven to accomplish something, you're really driven to pursue this pathway, you'll find experiences that further reaffirm it. I think it's very clear that people have doubts at times. So I did consider a few other fields, and I'm happy to discuss that as well. Let me just silence any interruption. But it was more affirming than anything else to continue on the pathway of neurosurgery. In general, yes, I think I silenced it to get an emergency call. In general, I decided quite early. But as I learned anatomy, as I was exposed to other fields, I, like many, felt like there's nothing else I could do. This was the field for me. And I did call upon those experiences to just get it from just a concept to actually a concrete fact. But I've never once looked back and said, I wish I did this other field. So I think it's okay for people in their medical studies to change. But in my case, I was kind of unilaterally focused on this end goal. But I think it's more normal to go at medical school and be very open-minded and take it all in, because the person that focuses on that one area will, of course, be prepared to go to that one area. But the point of medical school is to give us a broad education. So I would say my pathway is probably not the pathway I would elect for most people, but the earlier you know, the more you can focus.
Well, that's really interesting. And speaking of focus, I suppose the follow-on question is, getting into neurosurgery residency in the US is probably more competitive than just about anywhere else in the world that I can think of necessarily. What does this mean for you? Is that everything on step one? Is that publications? How did you go about that?
I think it's a combination of doing a moderate to great job on each particular area. So I do think board scores, publications are definitely at the top. I'm doing an away rotation, almost like a mini audition where you're spending 30 days at a facility, not at your home institution. I think that's so valuable, not just for the experience, but for procuring the letters of recommendation, the resources, but also seeing how medicine's practiced at a different facility. In general, there are other things, how one performs on their clinical rotations, a dean's letter. But I think the thing that is the most influential is how one performs on that away rotation, because the group that's interviewing the person gets to see not how they look on paper, but how do they function as a competent doctor, as a talented, having a talented skill set with their hands. How do they interact with the patients and the staff?
That's really nice to hear, I suppose, the fact that it's not, speaking to colleagues in the US, you often get this feeling that perhaps until recently everything was pinned on that step one exam and kind of nothing else really mattered. But if you're saying that actually there's perhaps a more human element to it, that's quite reassuring in a sense.
I like to think the field of neurosurgery, and I'm best at speaking about it stateside, but I feel like it's more holistic in that, of course, someone has to have reasonable board scores, a few publications, just to get the foot in the door and get the interview. But I feel like once a group of people is interviewed, it's not going to be the candidate that looks the best on paper. It's going to be the candidate that people want to work with, the likability, the competence, the being hungry for knowledge, hungry for being the best surgeon. I think those kind of things come out even on a Zoom call when we talk to people. We can sense their energy and devotion. And so I'm happy that the field is moving towards taking interesting people that provide a unique background that may not have been seen in neurosurgery as often. And we're going to promote that because it's going to make our field better. And that person's going to be a great neurosurgeon. Amazing.
Again, that's almost not what I expected to hear, but really quite nice to hear.
It's not just me. I mean, I sit through the interviews each year, and I feel like we as a field have to make up for the perceptions people have of us, that we're very good at studying, we're great test takers, we don't like to talk to patients. I mean, that's absolutely wrong. As much as I like to operate, when I run out to speak to the patient's loved one, to me, that's as valuable as the surgery I just did. I look forward to reporting to the spouse that the surgery went well. This is what we did. I look forward to my patient waking up so I can tell them I'm excited, almost like a little kid in the candy store. I'm excited to actually tell them what I did at surgery and how it was accomplished. So I feel like the field is making up for how studious it was perceived in the past and showing us more as humans and people that care. And we're not all about the science and advancing the technology, but advancing the patient outcome and the care.
So, well, this is the natural point, and this is the question that I really wanted to ask, because the reason that I reached out to you at all is on Twitter, you, for those who haven't seen Oren's profile, you have a very positive and supportive mindset, that seems to come through. There seems to be your angle, which is refreshing to see. So I guess my next question for you is, how did neurosurgeons come to have this very dour, antisocial, hyper studious perception, do you think?
I think that the great neurosurgeons of history were known for being great technical experts, great at scientific inquiry, but I think it was very inward facing, and they were taking on these challenges and promoting the field unilaterally without a focus on how it's perceived. I think all of medicine is more about, who makes the decisions these days. It's no longer a system where the doctor is suggesting a treatment or actually recommending the treatment. It's more of a collaborative approach. So I think all of medicine has changed. Social media helps, but I think we're all aware of how we are perceived and we get that feedback. And so I feel like someone could be great at some technical attribute, but if they're not great with their patients, there's a big divide. And I do believe the positivity and the human side will actually promote better outcomes. So I think I just represent a shift or a focus more on, just being more dynamic and being more, there's more to us than just like the doctor that comes in, that we all are people that have outside lives. I mean, I can imagine a time, even in my training, that mentioning the term outside life or balance, health, the health of the physician, these would all be not buzz terms. It'd be a sign of weakness. I think we realize that we are better doctors when we take care of ourselves. So I think I'm just speaking for the time.
No, I mean, even so, I mean, I'm honestly not 100% sure whether he's American or Canadian, but there's an ophthalmologist you may be familiar with on Twitter called Dr. Glaucomflecken, the comedian.
Of course, yeah.
And he obviously recently did a lampoon of neurosurgery, and it was this, this is our intern. He doesn't talk because he hasn't earned the privilege yet. All my residents are locked in a compound in the basement.
Exactly. Yes.
So it clearly does still persist, unfortunately, in some level.
Well, and he's taking a concept and multiplying it, an order of magnitude greater. But I think it's fun. I mean, I watched that and I was not offended, but I think he knows deep down that he's probably seeing, say his out of the hospital time as an ophthalmologist, he's seeing his colleagues in all fields valuing the time outside of medicine. So yeah. I did notice some neurosurgeons were a little offended by it. I think that's the whole point, but I don't think the neurosurgeons are working nonstop or not allowing people to talk. I think there's good rules that wouldn't allow that to actually exist in the current world. I think we have more checks and balance. You always hate the phrase when someone starts, when I trained, because you know where that's going to lead, but I did train at a time 20 years ago. So I have the benefit of seeing some of the older ways of teaching and the modern ways. And I'm just jealous of how things are taught these days. I mean, we use at our institution a feedback system, and I didn't create it, but I get the luxury of using it, where the residents in the OR actually prepare for a case, come to the OR, we can see their level of expertise. And then we're judged as attending or as the surgeon on how I train them. And then they give me feedback on my training of them, and I give them feedback on their learning. It's just a very open, transparent communication. Whereas when I trained, the feedback I would get as a resident was once a year, I'd have a written one-page sheet to read about everything I might have done great or not great for the year. So I just think medicine teaching and training is more collaborative. And the end goal is to train great, wonderful neurosurgeons, but also to do it in a humane fashion.
Definitely. I mean, I suppose that's a very nice segue into the notion that you are not just an attending neurosurgeon, you are a professor at one of the great American universities. So I suppose what led you down, because presumably there are many attendings who choose not to do that, or do not choose to do it. So why become affiliated with a university?
I mean, my passion is not only for patient care and doing good surgeries and having high quality outcomes, but I truly value my field. And that's not to say that there aren't other ways to do it, but the way I do it is that I'm involved with medical student education, resident education. I just feel that I owe it to the community to give back and I received good, solid training. So I just try to be the best teacher to our residents and our medical students. I think it's perfectly adequate for someone just to go operate and do well. I think in those practices, there are no distractions to that effort. Now, in my mind, training, that's not a distraction. It's actually a welcomed opportunity. But I feel like it makes life more interesting to be multifaceted. So it's just not giving lectures or doing research or working in the OR with the students. I just feel like academic practice is more holistic in that we're just taking on multiple attributes of the field of neurosurgery. But the luxury is we could be involved with all these different aspects, all by just showing up to the hospital. So, I'm not spending a lot of time in a lecture hall. Obviously we teach on the fly, and it's nice to be able to operate and actually educate at the same time.
That's amazing. Again, really nice to hear that sort of multifaceted, keep things interesting approach. And I suppose that I keep saying this, but there are a lot of questions and there are obvious pathways coming down. Do you have a favorite neurosurgeon figure in your life, whether that's a mentor or perhaps someone from history that you look up to?
Yeah, I mean, keeping it local is the easiest. During my tenure and time at Duke University, I've had a chair or the leader of the department, and over time we've had two different leaders, and I value that they've even added an element that I didn't mention as far as administrative and strategic development and advancing research. And we have a brain tumor surgeon that's always advancing the type of work as far as how are these diseases being treated. So I do have quite a few mentors. The interesting thing I see is my group practice is about 30 neurosurgeons, and it doesn't matter what level of seniority or how long you've been in practice, we all mentor each other. So it's the concept, that the mentee is actually mentoring the mentor, that it's not a role that goes by oldest to youngest, but we all have a service or a expertise. And so even our newer faculty teach me something, I teach them something. And I'm not speaking solely of operative techniques, but life lessons and specific, we've all come from different backgrounds. So I enjoy the fact that I have multiple people. I look up to all of them. We all have something special. We all have a specialty, but we also have outside interests that enhance our specialty in care of patients.
Amazing. Well, speaking, I suppose, of specialty, I realize that, again, things are quite different in the UK when compared to the US. And I mean, it might be just given the fact that most of the viewers on this channel are, I don't know, maybe in their teens through to their early 20s. I mean, would you be okay to run through just very briefly how neurosurgical training in the US actually works? Like, say I decide I want to become a neurosurgeon, what do I have to do?
Okay, yeah, I'm happy to. So, I mean, most individuals complete their high school education and, typically do 4 or 5 years of undergraduate studies. Of course, if someone's getting a MD, PhD and getting the PhD component, it's potentially far longer. There are some undergrad / medical school programs in the United States that combine them and offset a few years, but typically it's the undergrad education, and then medical schools typically the 4 years. But I know many individuals that have been very dedicated to research and did a 5th year or even 6th year. The neurosurgery training is usually an internship where someone's doing some trauma surgery, ENT, orthopedics, but spending some time on a neurosurgery service. And then it's usually another 5 or 6 years of devoted neurosurgery training. Most facilities have it squared away where there's like 3 or 6 month rotations with each specialty. In the middle, there's a research year, but some people elect to do an enfolded fellowship. Many do a fellowship at the end. Historically, people were doing that fellowship year at a different institution more often than at their home institution. But as many departments in the United States have every area of neurosurgery covered, it's less necessary to go outside of the facility. And then there's the question at this point, people go into either academic practice and start out from, a professor line, but not starting out as a full professor, or go into private practice. And even the word private practice has changed dramatically, where it used to be group practices, but many doctors are hospital employed in the States. So they work for a hospital, or they're in a small group practice that is affiliated with a hospital. So generally, the quickest route is 4 years of college, 4 years of medical school, 6 years of training, and a fellowship. And then at that point, people usually have a job. Not everybody lands on their first job in the States and sticks with it. There's a very high rate within the first, second, third year of people moving from that initial facility. I was lucky enough to find Duke University, and I absolutely love my position and the people I work with. So I've continuously worked there, and I plan to continuously work at that facility. But unfortunately, not everybody's that lucky that they landed on their perfect situation.
I see. And speaking thereof, I suppose, very briefly, now might be the time to ask, if you hadn't been a neurosurgeon and you had instead gone down one of these other things that you'd considered, what other specialty might you have found yourself in?
Well, it's hard to place myself back into the situation, but using hindsight bias of what I see now, I think interventional radiology has a lot to offer, and there's quite a lot in common as far as interventional radiologists doing, the aneurysm type procedures and stroke thrombectomies. So I think that would be perfectly suitable. And then there's orthopedics, where orthopedic spine, at least as far as I know, stateside, is very similar. Patients often ask me, should they have their spine surgery done by orthopedics or by neurosurgery? And my honest answer is always, have it by a good spine surgeon. It's not dependent on the training, it's dependent on the person and how they're practicing at this time. So I could easily see myself in those fields, but having done this for so long, I really can't truly imagine going back and participating in another field or having to go through training. I just think it's honorable when I'm talking to medical students and just think about how many years ahead you still have and all the energy. I don't know that I could do it again, but I don't know that I would ever do anything different, clearly.
That's a really, really interesting answer. I suppose all of those things are quite procedural, in a sense, maybe, rather than pure medicine, as it were. But that's really, really interesting. I suppose then one of the quite common questions that came in is that, particularly when you read, say, I as a young medical student read neurosurgical books and things like that, and there are some very famous American neurosurgeon books, obviously, and you kind of get this impression that they go in for pre rounds at 4 a.m. or whatever and don't come home until it's dark again. I mean, what might a typical day in your life look like?
Yeah, and I'm speaking now as someone that's been in practice for some time, and so I have more control over the day-to-day. But typically, I start answering electronic health record notes, like patients have written me overnight. So I start my day around 5 a.m. or so, and I do some research, do some reading, answer these messages. I usually either start a clinic around 7 or start my operative day around 7 o'clock. Surgeries can run into the mid-afternoon, late afternoon. I do have colleagues that don't mind operating all day. I have a very significant focus on quality over quantity. And maybe that's because I've been in practice for a number of years. And so usually the typical younger neurosurgeon is just running to do a lot of surgeries, to just be very involved in the technical aspects. I've taken on quite a few administrative roles within my hospital, within my department. And so I kind of have the day distributed between clinic, surgery, and then doing these administrative roles.
Cool. That's really, really interesting. I mean, it kind of, I'm surprised that just thinking about the UK NHS, obviously we have a much more, a much less privatized system, I suppose I should say. And obviously that's a conversation for another time. It can get quite difficult. I suppose one of the questions that we did have come in, which is quite complicated, but it would be interesting to have your take on it, is that in a much more privatized system, like there is in the US, in most states, at least as far as I'm aware, neurosurgery, I suppose, by nature of what it is extremely expensive. Now, in the UK, it essentially is the case that if you need a particular operation, you get it. There's no bill or anything. They try and be efficient, but if you need some really obscure tumor resection, then it will be free. How is access to neurosurgical care in the US, I think, is the question.
Yeah, I mean, again, the answer, there's so many aspects I could address. I think that there are still groups within the United States that suffer for too long, meaning there's not equal access. And there's no system that could correct that. It's just there's a local, every state, every city, every hospital, there's just not equivalent access for all groups. And then when people come in, I tend to go see patients and I try to not look at their insurer. But when I establish what their plan is, like the patient tells me I want to have surgery, I have to actually then take note of who is their payer. And then I have to tell them how quickly the surgery may be approved. What are the guidelines that the insurer requires? And it's very troubling to me because the guidelines aren't even consistent. And the guidelines aren't always based on evidence-based recommendations, or, we use the term guideline concordant care. And so it's very difficult because I feel like I can't even be the best doctor. I have to look into all the rules and regulations, not by a medical team, but as prescribed by an insurer.
Yeah.
And so in general, I feel like any effort to improve access, and then when we decide when to do surgery or not, it's really a physician's decision, with obviously the patient's decision, but physician agreeing. And I just feel like there's so much more we could do to reduce that variability and use objective evidence. So very complex, but I do some work on disparities in healthcare delivery. I do work on social determinants of health. And I think we're all in our infancy on these issues, where I just feel like we haven't figured it out. And I think having the privatized system, it just complicates things even further, because at least if you're delivering care in a similar manner and there are disparities or there, inefficiencies or inequities, I think it'd be easier, not simple, never simple, but it would be fundamentally part of the care that you could figure this out, with everybody having different payers. And I honestly never know what percent is my patient going to have to pay for this. And if I knew that, I would definitely change my treatments, because I would always, if I knew there was more out of pocket cost, I would always want to be efficient, but I'd really feel for that person that's paying more. It's just one of the biggest concepts that really upsets me is that the same exact surgery for two different insurers are like not even the same order of magnitude different. And it's like, I'm the same surgeon, I'm providing the same quality of care. Why would it be worth more to one system, not the other? That really bothers me. I wish it wasn't like that.
Okay. Yeah, that's really interesting. I'm sure that no health system that exists has probably worked out the answer to that one, but it's certainly interesting to hear that. Now, something perhaps a little lighter, for want of a better phrase, when I spoke to you before, it became apparent that you are involved as a consultant in some television series. Is that correct?
You are correct, yes.
I mean, this springboards a load of questions, I suppose. Which series? How did you get involved? Why? All the rest of it?
Yeah, so I mean, my time at Duke, 11 years, when I first started, I was just looking to take care of the community, be available as a neurosurgeon, but I received a phone call. And in North Carolina, I have the code to know that it's a North Carolina phone. This was a Los Angeles phone number, California. And, just being open to trying to help, I called it, and it was a TV writer, and he was working on a pilot, trying to get a TV show, started up about a neurosurgeon that's trying to solve his own illness. And so I thought it was fascinating that I could basically think outside of this box of how we look at things in medicine and try to educate this writer and try to educate an audience about what neurosurgery is truly like. And I think everyone in medicine has found a time where they've turned on a fictional TV show and just rolled their eyes or shook their head or stomped their feet because there's a way to accurately depict what they just showed, but the writers, one, did not have the knowledge of what reality is, or two, didn't have the resources to seek out an expert, or three, really didn't care at all. So I felt like this was my in, where I do care. I do not want to ever belittle or put down a disease, like use a disease that many people are suffering from for entertainment. But to flip it, if we're going to show a disease, let's show the true human suffering, the true options. And we might be showing an extreme scenario, but it still exists in the realm of reality. So this one phone call led to working on a few shows, and those writers worked with other writers and referred me to other shows. And over time, I've contributed in some small way or larger way to about 50 different television series, but I've been a regular consultant or expert to several shows. And, I can list them. There was a show, Elementary, that was an American version of Sherlock Holmes that was on for 7 years. As a physician, I wasn't just providing how to use medical knowledge and science to solve the case, but I actually had to contribute, how did the evil murder person make this crime hard to solve? So I looked at it, I got to help with actually developing the crime scene and what went wrong, what went on, but then I would also help, the equivalent to the Watson to solving the case. So I worked on that for 7 years, and there was a level of discomfort thinking about how medicine can be used against humans, but then also just solving the case was kind of fun. So that was one of the shows that I felt like was different than the others. But typically I help on shows that are hospital-based or clinic-based, and I pitch stories, I help the writers develop their stories, and rarely I even get to write stories.
That's incredible. I mean, do you happen to have a favorite medical TV show? Can you tolerate them in your position?
Well, so I take a different look at it. So now that I'm on this side of helping, I watch medical shows with the question, what did they get right? But most medical students and physicians look at the show and say, what did they get wrong? And so any show that's consulted an expert and has put in the time to try to make it look real, you'll actually watch and you'll listen to all the correct terms. You'll see scenes that actually look real. But there are shows that aren't medical, and then they have an episode that's particularly deep in medicine. That's where they can go like brutally wrong, because they don't know that they need to seek the expertise of someone like myself. That any show could call me right now, and I mean, I've helped on cartoons, I've helped on science fiction, on romance stories. The point is, if they're going to show medicine, I need it to be accurate. And so again, I can watch any show and see what they got right, but I'm no longer going to be that person that screams and says, you got all this wrong. But I don't like shortcuts. If there's any way to not change a writer's story and keep the medicine accurate, that's a win for me, and that's a win for all of us medical types. So my goal is to never upset or disrupt the writer's great ideas and their, the drama of it. But sometimes I do have to substitute one disease for another, like the disease just doesn't fit, or the way they're describing the disease is going to upset a proportion of people with that particular problem and mislead an audience. I don't like shortcuts or misleading audiences.
That's a really insightful answer, actually. Genuinely something that I'd never even thought about, being on both sides of that that arrangement, if you like. And just because Zoom is blinking at me, as a final question, and I'll let you return to your incredibly busy schedule. A lot of people asked, and I think this was the most popular question, I suppose, it's if you could take away one life lesson, as it were, one golden rule from your career so far as a neurosurgeon, do you know what that would be?
Yeah, let me reflect on it for a second.
No problem.
I think that in general, I'm going into a field like neurosurgery and trying to be, and I've alluded to some of these terms along the way, but just trying to be a technical expert. And trying to, you kind of have to be thick-skinned and hard, to be able to tolerate some of the awful things we see, the human suffering, the struggles, the difficult decisions. But I think keeping one's humanity as we do that. And so kind of checking in and thinking about the bigger picture. So when I go do a surgery, I am focused intently on doing that surgery well, but I can stop and look around the room and make sure I'm taking care of everyone in the room, that I'm being a good person. Someone could be a great surgeon, but be awful to work with. So I think being mindful of every interaction we have in life and truly, honestly, trying to be a good person and trying to be an educator at all times. So I take any opportunity to teach anybody that's interested in our field something about it. I, really listen when people tell me their stories. Their patients are telling me about their suffering. I really try to feel what it feels like. So I think that my fundamental life lesson is being mindful of everyone around you. Everybody's, going through this world, but it's our job to listen better and try to, be our best each person. So I just try to be a good person to everyone I interact with. But it's hard as a neurosurgeon because sometimes we're faced with difficult situations. I could get into the OR and the patient is having a harder time at the surgery than we would have expected. But it's my role to try to keep gentle, keep kind, keep everybody, not overreacting. But all of these things are complex. So I would just say holding on to, we all became doctors for a reason. We all became neurosurgeons for a reason, but trying to have that excitement we had before we got into the field, try to keep that going. And so those are themes that I try to work on every day of my life.
That's amazing. And that is a really poignant, wholesome and insightful way to end this talk. So thank you so much, Dr. Gottfried, for coming to speak to us today. We will make sure that all of your relevant contact details and things are on the video and down in the description box, so people can come and follow you on Twitter and on the platforms. Do you have any final remarks?
I would comment that if I didn't answer all of the questions, I really encourage everyone to, direct message me, or you can give my email address out, and I just want to answer those questions. I'd love to learn about all of your audience, all the great things they're doing. So this kind of, bilateral communication would be great for me. So I encourage everyone to reach out, and I'm happy to describe how medicine appears over here, but I also just want to learn how globally medicine's practiced and how we can advance the field and how we can advance neurosurgery. And I'm excited about your interest in neurosurgery. So of course, I'd like to help at any point if I could.
Amazing. Thank you so much, Dr. Gottfried, and all the best for
Thank you.
the many amazing things to come.
Thank you. I enjoyed speaking with you.